Okay, so good afternoon and hello, my name is Robert Friend. Welcome to our second live session of the NHCP Virtual Wellbeing Festival. This session is all about physio myths and misconceptions, plus we are going to have a TheraBand workout. Our guest speaker, Stephen Rigby, will be debunking some myths and misconceptions commonly seen in physiotherapy, challenge pre-existing concepts and bias. So I'm going to be joined as well by my colleague Anne, who's going to be working behind the scenes, answering any questions or helping me facilitate the questions in the chat box and asking any questions that you have on your behalf. So just going to run through some general housekeeping. So can we please ask that you keep your cameras and microphones off for the time being? We are going to be encouraging you later on in the session to switch these on. We want the session to be as interactive as we can. Please use the chat function to add your thoughts, comments, or ask any questions. Or alternatively, you can use the raise your hand function at the appropriate point and come onto camera to ask your questions directly. If you don't have access to the raise your hand function and you want to come onto onto screen, please post the question into the chat and say that you'd like to ask the question yourself. We may be using breakout sessions throughout the session, breakout rooms. When we move into breakout rooms to enable, bear with the conversations as we go along. Also please also note that we are recording the session and you should be notified of that already. And this is so that we can share with colleagues who haven't been able to join us today in the session. For colleagues that have a hearing impairment, you can turn on the live captions by clicking on the three dots at the top of your Microsoft Teams and then clicking turn on live captions. This is only enabled on computers using Microsoft Teams apps, so unfortunately there isn't a feature on phones or iPads. So at this point, I'm going to hand over to Stephen Rigby, who's going to talk us through the session, and yeah, looking forward to it. So over to you, Stephen.
Thanks, Robert. So I thought today we would talk about some of the common myths and misconceptions that I see clinically, as do lots of my colleagues, commonly sort of day in, day out in practice. And a lot of these myths and misconceptions can contribute to people's sort of health anxieties. They can drive a lot of, sort of negative health beliefs, and it can really impact on people's physical and emotional well-being. So Robert's just put up a slide there of the 6 myths that I'd like to talk about today. And what I thought would be really good, if you would like to simply just comment option 1, 2, 3, 4, 5 or 6 as to which of those myths you would like to talk about first. And then we can work our way through the topics and we can talk about some of those myths. And I'll try and give different sorts of examples that we will see clinically. I'll try and bring in some evidence as well. And you're more than welcome to ask any questions during the presentation. At certain points as well, I have got a TheraBand here. I was due to have a colleague help me out today, unfortunately she's ill. So I'm just going to be showing some exercises that you can do using a simple piece of TheraBand, which is they are latex bands, but they can also be latex free, and you can do some exercises from your office whilst you're working at home, or even whenever you've got some spare 5 minutes. As part of your physical well-being, it's good to keep moving. So I'll let Rob and let me know as to which one we'd like to talk about first.
Okay, so looking at what's coming through in the chat, I think you'll find, Stephen, that most of them are going to be coming through, but the one that's we're seeing the most of at the moment is number 2 at the moment.
Yes. Okay. So talking about sort of posture, really. So we'll start off with number 2, which is talking about sort of bad posture causes pain. So this is something that we see an awful lot of in physiotherapy. We have an awful lot of our patients come to me and my colleagues experiencing neck pain or back pain. And one of the main reasons a lot of patients will cite is that, you know, I've got bad posture, this is what's causing my pain. And I think this stems an awful lot about culturally and individually what we've been told to think about posture. You know, I'm sure plenty of us have been told to sit up straight, stop slouching, and you'd probably be friends and family point out to you that you've got a bad posture. To give a bit of reassurance around it, hopefully, and then hopefully explain a little bit about posture will hopefully serve to ease a lot of your anxieties around it. And I think most of the time posture is demonized an awful lot. It is seen as the bad guy, it's seen as the culprit, and lots of people attribute bad posture to them having these sorts of symptoms. Quite often we see it in the media, and we see sort of beliefs around certain postures causing neck problems, back problems, headaches, digestive issues. So it's very, very topical, it's very, very popular, and it's something that we see an awful lot of. Our patients will say that I've got a bad posture. I suppose from my perspective, first and foremost, I would say that there is no such thing as a perfect posture. As human beings, we are incredibly variable in our anatomy, how we've been brought up. Lots of different situations have resulted in us being who we are at this moment in time. So I've been alive for 34 years. Through what I've been through in my 34 years can result in me developing some sorts of pains. It's not all down to the posture. My anatomy is different to Rob's, it is different to Anne's. Everyone's got a different anatomy, and what I might find as a comfortable posture, you might see it as a bad posture, or what you might see as a bad posture, I might argue, well, that's a really comfortable posture. So there is huge variability, not only in what people's anatomy is, which will allow them to adopt a certain posture, but there's also huge variability in what people perceive as being comfortable. I did a presentation not too long ago talking about neck pain and posture, and something we hear an awful lot about is mums and dads now of young children who have got mobile phones, and they're often told, text neck. So people who are looking down at their phone an awful lot of the time, and people are saying that is what's causing neck pain. But if that was the case, we've for many years we've adopted this forward head position. So reading newspapers, reading books. So if that posture was attributed to neck pain, we would have known about it by now. It simply isn't the case. There are lots of other things that can contribute to an individual having neck pain or low back pain, which we will talk about a little bit later in a couple of the back pain myths that I'm talking about. So an individual who let's take the neck, for example, who has a forward head posture, so where the chin is buttoned slightly forward, we might say that is a classically bad posture. Now, lots of evidence, lots of research has taken that forward head position and has actually identified that alone is not the cause of someone's neck pain. So they took, you could take 100 people who don't have neck pain and put them in this position and they won't develop neck pain. But equally, you can take 100 people who have an existing neck pain, put them in this position, and their neck pain will get worse. And what they found out is that it's not actually the posture that the individual is in which is causative of them having that neck pain. It's actually the musculature around their neck. So we found that individuals who more often than not have got neck pain have got weakness in the muscles of the neck. It so happens, it's kind of cause and effect there, that those individuals with neck pain who have got weak muscles of the neck are more likely to adopt these sorts of head positions and these sorts of neck positions. So in summary, this position in itself isn't bad and doesn't cause neck pain. However, if you've got a weak neck and you've already got neck pain, then this can cause neck pain. From my perspective, the things that I think we could focus all on, especially working at home, working on our computers during the pandemic, is not being so preoccupied with the posture that we're in. What I think would be good for you all to focus on is the time at which you spend in that posture. So I could sit slouched to one side. This is technically a bad posture, but if I don't sustain this for more than 15 minutes, I can quite comfortably change position and move to other positions. So the most important thing that I want you to think about is the time that you spend in a posture, because your spine is designed to move and it wants to twist, it wants to turn. If you maintain that posture for more than 15 minutes, you can develop stiffness and you can develop muscle fatigue. The muscle fatigue and the joint stiffness are what we think are more likely to result in that individual experiencing pain. So a takeaway message for you to think about is the next posture is my best posture. So we want you to move around regularly. So lots of phrases that we use in physiotherapy that you want to think about. Motion is lotion, so get yourself up and about, moving every 15 or so or 20 minutes if you possibly can. It's that change in posture which will help prevent you developing aches and pains. So motion is lotion is a good phrase to remember. Rest is rust is another one. So the more time that we spend inactive, the more we are likely to experience pain. So if you think about individuals who perhaps had surgery and who are lying in bed, perhaps bedbound, they can very quickly develop muscle wasting, and we know that that can contribute to the individual's levels of pain. So motion is lotion, rest is rust. Sit less and move more are probably the most important things to think about with regards posture. Don't demonize a slouch posture. Don't demonize a forward head posture. Just change your posture regularly, and that is what your spine wants to do. Your spine is an incredibly tough structure. It's designed to protect your spinal cord. So it's probably the strongest part of the body, surrounded by incredibly strong ligaments, incredibly strong muscles. It wants to move. Each motion segment of your spine has a degree of movement that it wants to do. Same way as my elbow has degrees of movement that it wants to do. And if I put my arm in a sling for 6 weeks and restrict that elbow's movement, I can develop an elbow stiffness and I can develop pain. So if movement applies to the elbow joint and the concept of movement to help a joint stay healthy, it applies exactly the same for the spine as well. So motion is lotion, rest is rust, sit less, move more. So hopefully that's sort of addressed that myth, and hopefully it's challenged some of those misconceptions around posture and demonizing posture as a cause behind people's pains. So I'm not saying posture is irrelevant. I just don't think it's as pertinent or as big an issue as we typically give it. Okay. So has anyone got any questions that they would like to ask there at all?
Yes, Stephen, there's a question that's come in from Joanne. Joanne, I don't know whether you want to ask Stephen directly or do you want me just to read it out, but whilst you're responding to that, Rachel Barber has said, if you don't use it, you lose it. So another phrase that goes with your motion is lotion and rest is rust.
That's a fantastic phrase. Yeah, really well done. Good phrase.
Yeah, no, that's good. So the question that came in from Joanne is she talks about her lower back discs exploded, so no longer have discs in my lower back. I've now got pain in both hips, even more pain in lower back and pain in my left calf. Before I get I now have the sensation back, but I get pain and cramps in the lower leg and find it hard to exercise to find an exercise that does not aggravate the pain. And I think this is all seems to be triggered by a C-section 17 years ago. And she has had her back described as being like a table and does not move because of the C-section. Can you make sense of that? Because you're the expert and I'm not.
That's probably, I think we try as best we can to not go down individual clinical cases, because everyone's going to have their own individual experiences of these things. For that case, I would say if you haven't already, possibly refer yourself to physiotherapy and have an assessment and have a discussion with a physiotherapist about ways to help best manage your back pain. But it kind of ties into some of the things we're going to talk about a little bit later. So a few of those other myths that we'll talk about with around back pain and sort of changes that occur to the back, we can talk about that in a little bit of time, but trying to get away from individual, because otherwise I'm just conscious I don't want this to become a physiotherapy assessment remotely. I think you're on mute, Anne.
Anne, sorry, you're on mute.
Oh God, I'm on mute. I'll start again. I'm not doing well here. So the question was, are there ways in which you can move joints when you can't stand up and down frequently? For example, on a bus or a train or hopefully one day on an aeroplane.
Yeah, most definitely. Exactly. Motion is lotion, rest is rust. You know, those are the quotes that people said. If you don't use it, you lose it. So whilst you sat down in a bus or in a car or in a plane, awful lot of movements you can do for your neck. So you can take your neck through the full range of movement. You can tilt your head from side to side. You can rotate over each one of your shoulders. You can take your neck up to the sky, bring your chin down to your chest. So you can take your neck through its full range of movement. Coupled with the flexibility side, you can do some gentle strengthening exercises for your neck. Simply put your hand either side of your head and push as hard as you can into your hand. That will help keep these muscles of your neck nice and strong, which if you remember when we talked about posture, most people with neck pain have got weak muscles of the neck. So if you can keep your neck muscles nice and strong, that can be really good. And also not just thinking about the neck or the lower back, we've also got a big part of your spine in between called your thorax or your thoracic spine where your ribs attach. So you can do some rotations, you can do some side bends, even reaching your arms up as high as you possibly can all take your spine through some good range of movement. So although you won't be standing up and twisting and turning a great deal, you can still get those movements which you'd really, really benefit from whilst you're sat down.
Okay, brilliant. Thank you, Stephen. And I think the next question comes in is about core muscle strength, but I don't know whether you're covering that in a bit.
Well, we can talk about that now if you like. We can talk about core strength. It's another myth that we get, or we talk an awful lot about with patients is core strength. Now it became a very popular term, core strength, in about the early 1990s. I think there was one study which looked at the timing of an individual's ability to contract a muscle of their core. So transverse abdominis was the muscle in question. And they found that a delay in that muscle contraction was associated with low back pain in the individuals that they tested. The thing that most people, they tend to take that study at face value and focus on that and that's the takeaway message that they get, that I've got a firing problem or I'm not timing my muscle firing. Whereas actually I think it was 0.005 seconds delay in timing of that muscle firing. So we're talking very finite things here, which in all honesty, don't make a great deal of difference. When people come to see us in physiotherapy, we hear a lot of the time, I have back pain, therefore I've got a weak core. I must do core strengthening exercises. I need to brace my core. I need to find neutral. And I think core exercises, of which the spectrum is very large, from yoga, Pilates. In fact, you could argue any exercise is a core exercise, to be honest. But specifically mentioning yoga and Pilates, they were very much seen as kind of the holy grail to low back pain, seen as the silver bullet. This is what is going to fix society's problem with low back pain. In reality, it's a very simple answer to what is an incredibly complicated subject. You know, low back pain is incredibly complex. It is multifactorial. An individual with back pain has got several different factors there, or several different ingredients that can contribute to that individual's perceptions of back pain. So things like cultural beliefs, historically what's happened to them, family history of back pain, how they are feeling in themselves. So we talk about stress, anxiety and depression, polypharmacy, taking lots of medication, other health conditions. All of these things can contribute to an individual having low back pain. Ultimately, for the vast majority of individuals who fall into a non-specific back pain, so that's where there isn't a pathology that can cause it. So excluding things like a bone cancer or an inflammatory back problem or a fracture, or those sort of small percentage of things that can cause back pain, very rarely. We're talking about the greater percentage. Those individuals, we don't know what causes it. All of our thinking around back pain is theory in its sense. What we do know is that the concept of core muscle strengthening was based around the muscles of your abdomen, the muscles around your spine. So your they're all posh names, you don't have to know them. Transverse abdominis, obliques, rectus abdominis, multifidus, pelvic floor, all of these muscles that work as a kind of to brace your spine or to help to support and give you stability. The difficulty with core exercises is that the way it's taught is very complicated. If you've ever been to a yoga or a Pilates class, how core exercise is explained is very, very terminology based. For a lot of people with low back pain who perhaps have never been involved in any exercise in their life, who, you know, a lot of them haven't got that body awareness, and a lot of them are often quite scared of doing exercise. Pre-COVID, if they was to go to a gym and be involved in a yoga and a Pilates class, even at its most basic level, can for those individuals be a very intimidating environment, can be very complicated. They can feel very self-conscious and aware that they're uncomfortable in that environment. So the core strengthening exercises is where we're trying to, the people who teach, I'm not demonizing instructors, I'm just trying to give an overall different perspective to it, is that we are telling individuals to control the rate at which they're contracting these very small finite muscles. So we're giving individuals, or we're trying to teach individuals to consciously control muscles that previously they couldn't consciously control. So they're kind of always active. So in essence, especially for someone who's not done any exercise in their entire lifetime, who's scared of movement, it's like we're asking them to go into a Formula One car, drive in reverse around Silverstone with a blindfold on. It's just, for that individual, that exercise perhaps isn't appropriate. Yes, they might have low back pain, but that exercise might not be the answer to that individual. So it's not me saying core strength or core exercise is rubbish. No, in fact, it can be incredibly useful. It can for some people be that exercise that they need to do to help them. For other people, it's not. Getting individuals to control some of these muscles that they don't know that they had. Sometimes I like to give the individuals an analogy. I'll say, can you get in and out of a chair? Can you stand up from a chair for me? And quite often they will brace their spine, they'll find neutral, they'll tilt their pelvis, and they'll stand up and they'll breathe, or some of them might even hold their breath. I'll then say, can you sit down? And I said, if a grizzly bear walked into this room right now, would you do the same thing? Or would you just get up and run? And they say, I'll probably get up and run. So we're overcomplicating something, normal human movement, that perhaps we don't necessarily need to. We're perhaps making exercise unattainable for a lot of people due to the complexity of it. Another way to think about, do you need to brace your core? If you've ever seen a child bend down to pick up an object off the floor, do they pause before they do it to find neutral, to adopt a manual handling posture? No, they don't. They just do it. They just move there. And that's probably because children and babies haven't got that biopsychosocial multifactorial element behind pain. For an individual who's bent down previously and injured their back by picking up a plant pot or a pen, there's a certain guarding around that movement pattern now where they perhaps wouldn't like to do it because it's associated with pain, which is what we get. So for some individuals, core exercising isn't great. For others, it's fantastic. So postpartum, for individuals who've got a condition of the spine where it's slightly unstable, for individuals who've got stress incontinence, core exercises can be wonderful. I just think we have to be a little bit critical. And is that exercise pertinent and relevant to that individual? Another analogy to think of is if you took your car to a mechanic, or you took 100 cars, all with a mechanical problem that we're not sure about, and we all took them for a service, and the mechanic just changed the oil on every single one of those 100 cars, you might get some of those cars better, and that will be the thing that car needed to work. But for the majority of the cars, it won't work. So you can't take an intervention, apply it to a population and expect a single outcome. There's got to be lots of variability there. So if for you haven't exercised or you've been relatively inactive, the best exercise you can do for your low back pain might simply be going for a walk with a friend regularly. It might be going swimming. It might be buying some foot pedals. It might be yoga. It might be Pilates. It might simply be going dancing or doing some Zumba. So the challenge for us, and not only as health professionals, but for patients, when I've been a patient myself, is finding what works and what's best for me as a person and what's going to help me feel better. So Pilates and yoga is one way, it's not the only way. Core strengthening is one way, it's not the only way. So it's trying to find what works best for you. So I hope that sort of reassures a lot of you out there who feel like you're worried about you've got a weak core and that you should be doing yoga or Pilates. It isn't quite as simple as that. You might just need to do something else regularly and routinely to help with your back pain.
Okay, brilliant. Thank you, Stephen. That was really useful. So another question that we've had in was, could you supply some exercises for staff to do when they're in the office and not able to get up every 15 minutes? And could this be taken forward to allow staff to do exercise while sitting and walking around the one-way system in the office?
Yeah, so I think we worked on sending out to NHFT staff. I think me and Anne, we worked on sending out wellbeing packages, which we included some exercise in there, which I'm more than happy to share out at the end of this presentation. We can circulate that. A great exercise, if you wanted to do it, is simply sitting on the edge of your chair, on your office chair, placing your arms across your chest and just lifting your feet off the ground. For some of you, that might be too hard, so it might just be that you lift one leg up at a time, almost like you're marching really slowly, lifting one leg up at a time. So in essence, it's a core exercise. It's not yoga, it's not Pilates. It's an exercise to work on the muscles of your stomach to help keep you nice and strong. And you can always advance that exercise by introducing some arm movements. So as you lift up your legs one at a time, raising your arms, you can lift both legs, both arms at the same time. Anything like that is a great exercise to do, and you can even do it on a train. You can do it on a plane. So you don't raise your arms up too much; you might scare other people. But doing some sort of movement, any form of exercise you can do whilst you're sat down in a chair is a good exercise. But like I said, I can send out the exercise sheets and send it around to Anne and everyone else so they can circulate it for you.
Brilliant, thanks, Stephen. And one more question on this subject. Any suggestion for leg exercises to avoid cramp when sitting at your desk? I know it's best to get up if you have to sit for a period of time, but do you have any suggestions to be able to keep the blood moving?
Yeah, so ankle pumps. So simply lifting your heels off the ground, getting the calf muscles working, because they're really important to help pump blood from your feet back up to your groin. So if you've noticed that your feet are swelling whilst you're sat down, you need to start doing some ankle pumps. The same reason that when you're on a plane for a long period of time, you do these exercises to help avoid a blood clot. So marching up and down, you can scrunch your toes into your shoes or into the carpet. It's a really good exercise for you to do to help prevent getting cramp. A really nice exercise to do is just lift up your leg off the floor, put both hands on top of your leg and push your leg down, almost have like an arm wrestle with your leg, and do that on both sides. Or if you even just putting your hands onto your thighs and lifting up both of your heels by pushing down, you're getting a good exercise there as well.
Brilliant, thank you, Stephen. I have visions of everybody off camera doing all those exercises. So, thank you. And again, if people want to come on camera to ask Stephen a question, then please don't hesitate to do so. So I'll let you carry on, Steve.
Which myth would you like to talk about now? Should we talk about pain is equal to damage? Talk about that. So yeah, so pain equals damage. So historically, pain and damage are not good bedfellows. They don't particularly go very well together. There's a huge amount of disconnect that we see between pain and damage. We see individuals who've had x-rays, ultrasound scans, they've had every investigation under the sun, and there's no damage there that can explain the pain they're in, but they might be in considerable amounts of pain. An alternative, we see lots of individuals who have got quite extensive damage but experience no pain. So there's huge discrepancy between pain and damage. I think what's really good to know is to get a definition of what pain is and then kind of work back from that definition. So it's an unpleasant sensory and emotional experience which is associated with actual or potential tissue damage. So effectively, pain is a bit of an alert system. We've got some people who might have really advanced and sensitive alert or security or alarm systems. They've got Alsatians, they've got laser beams, they've got CCTV. Think of Mission Impossible when he falls and all those laser. So people's nervous system is inherently slightly elevated, and other people's it's not. So pain falls into what we like to work at is within a biopsychosocial model. So there's a biological component, there's a psychological component, and then there's a social component. Now, the most important thing that I'd like to convey and get across is that pain is real. It's very, very bespoke and individualized as well. And the pain that you experience is different to anyone else's. It's a lot of different things. It's a sensation, like touching something is. It's an emotion, a bit like fear or anger. And it's a behavior as well, almost like when we get hungry. And it's lots of different components to it. It's incredibly complicated. Pain is incredibly complex. Effectively, it's a perception, or the brain's perception, about threat and damage, and how that perception is interpreted, and then you get a byproduct, which is pain, or that negative experience of that hurts, that's not nice. So that's effectively what pain is. To give you an example about pain and damage to help you think about it, have you ever woken up in the morning and you've got a bruise on your arm or your leg, and you're like, how did that happen? How have I got that bruise? Where's that come from? And you can't explain it, and it didn't hurt. And you're like, oh, that's strange. There's still a degree of damage there. There's still been tissue damage. You've ruptured blood vessels, you've got red blood cells broken down, which give you that colour. So there has been damage, but you haven't got pain. Conversely, have you ever had a paper cut on your finger, and it's the worst pain you've ever had? It's excruciating, and it's just from a small amount of damage. So a bruise and a paper cut are the same level of damage, relatively speaking, yet there's huge discrepancy in the perceptions of pain. So pain doesn't always equal damage. I mean, sometimes it does. Sometimes if a car runs over your leg and it hurts, there will be damage there. So there is a biological component to it, most definitely. Except the level of damage doesn't always correlate to the level of pain. Another way to think about pain is a perception of threat, or the potential for damage. There's a couple of good things to think about. One is, if you go to touch something really hot and straight away you pull away, so the pain you have pain there because there would have been damage if you kept your hand there. So in that respect, pain is good. It has helped you. It's your friend, and it's protected you in that sense. Or if you've ever been walking and you've got a stone in your shoe, and it hurts, doesn't it? But it's not really caused any damage. But if you was to walk a marathon with that stone in your shoe, it probably would cause damage. And we've also got to take into account your body's ability to tolerate with physical stress and emotional stress and different loads, and how that damage relates to that. So if you've ever seen a rock climber or a weightlifter, they've got huge calluses on their hands where the skin has become really thickened because it's used to lifting bars or climbing on rocks. Technically, it's damaged, but that damage has occurred slowly over a period of time, and the tissues have adapted to that level of damage so that it doesn't cause the individual pain. Whereas if you took a novice to the gym and got them to lift weights, or took someone who's never done rock climbing before, they might develop blisters, which are really painful. But it's relatively the same degree of damage, just that one has occurred over a long period of time and the body has got used to it, whereas another type is quite acute and it's caused quite a lot of pain. So there's that element to it as well, the body's ability to adapt to that pain. So it doesn't always mean that you've got damage. I think a couple of things that I want you to think about is that our behaviours and beliefs can influence pain. So I don't want to exercise because I know it's going to be bad for me, and I'm scared about pain, so I'm not going to do it. And pain can also influence behaviour. My knee hurts, so I'm not going to exercise because I don't want it to hurt more. And a lot of that is because of adults, and what every single one of us has been through in our entire life has moulded us to that point that has influenced your decision and your beliefs and your behaviour. Whereas if you take a child who's been on a bouncy castle and they've bumped their head and they come off the bouncy castle and they're crying, and you give them a cuddle, and they've got a little bump on their head. You give them a cuddle, they've had a cry. Once they stop crying, the first thing that child will do is go straight back on the bouncy castle and play, because they haven't made that link in their relatively short lifespan. They haven't made that link between the negative experiences and associated with pain. Whereas adults, if we fall off a bike on a bike ride, or we fall off a horse and we hurt ourselves, we're much more hesitant to go back and do that activity. So our behavior is dictated by our experiences through our lifetime. So it's not necessarily because when you've fallen off the bike and you've grazed your knee, that's the worst pain that you've ever experienced, or that's the most amount of damage you've ever experienced. You just now have made that link in your brain that goes, oh, I don't know if I want to do that again because it was unpleasant, or I don't want to cause any damage further on the line. So there's your sort of your psychosocial element. That's the psychological impact upon it. We need to consider lots of different variables when it comes to pain, not just damage. Yes, in certain cases, there will be damage. If you break a bone, it's going to hurt. But for these persistent pains that we have, these chronic pains that have been there for years and years and years and years, we could argue that the damage perhaps isn't getting any worse because we would have been quite poorly and quite unwell, especially if it progressed. I mean, there wouldn't be much left to us, would there? But it's the picture of that whole presentation, that everything else that goes into that presentation that makes you feel that way. So yeah, behaviors, influences, lots of different factors there, levels of threat. So there's an interesting theory about the vulnerable organism, where if you've ever been like sad, depressed, down, anxious about something, you're much more likely to catch a cold because you're immunosuppressed, your ability to fight things has been reduced. And that can mean that you have a little bit more pain as well. So lots of different things. Think of it as a jigsaw. Pain is a jigsaw, especially back pain. And there isn't a quick, simple explanation to it. Very rarely it's to do with damage. Sometimes it is, but very rarely it's that as a single factor. Okay, any questions? Any questions on that?
Taking myself off mute in plenty of time this time. Learning. Yeah, I mean, the couple of comments, I mean, I put a comment in to say it was really interesting about the beliefs and pain, and I personally not made that connection before. And having cared for somebody that had quite a bit of pain, the belief that moving, going back to your first thing about moving more would help, was really ingrained, that she didn't want to do it, so therefore she didn't. So therefore, the move it or lose it piece came into mind. So there's quite a long question from Rachel. About physio. I don't. Can you see that question?
Oh yeah.
So
Stephen,
it's quite a long.
What was one? Yeah. I guess this would be my last question, I think. When seeing the occupational health advisor who then advises you'll need physio, why is physiotherapy plus recovery exercises outsourced? This must cost the charity. I don't know how much suffering did was working with nutrition. And we have qualified staff that first and foremost attend to our patients in care. Why not have physiotherapy staff to help the staff? Should I say charity to qualify for some money? We have facilities available to us. How many times did charity let down by outsourced contracts? Yeah, I think that's I'm not sure if it's a
yeah, just.
But I think it goes to show that the value of having physiotherapy or having a discussion with somebody around your beliefs around pain, somebody who listens to your concerns, your ideas as to what you think the causes of that pain are, and working closely with you about your expectations and what it is that you want to get out of your physiotherapy sessions, and ultimately if you've got any goals that you want to work towards. Because I think physiotherapy has got the word in itself, physical. Yes, we look at people's physical problems. We consider ourselves movement specialists. We look at weakness, we look at tightness, we look at damage. But there's also a therapy side to it as well, where there's that listening to people's problems and all of those things, having those discussions with those individuals about, especially with persistent pain, about what is causing that pain, what are the main drivers behind that pain. And quite often than not, when you have those discussions with individuals, it's really good because they thought, oh, it's arthritis, that's why my knee hurts. But actually, is it really? Or is it because someone told you that you've got a bad knee? Is it because a relative had a knee replacement which went really badly and now they're struggling? Or do you know someone who's been in a wheelchair because of arthritis? So there's lots of different things there. So it does go to show you that if you get a physiotherapist who you talk to and you get on with and you feel comfortable talking to, you know, try having those conversations with them. It's very difficult, it's very hard, but it might allow you or your team or whoever is involved in that to really optimize the therapy, the physical therapy that they're getting to ultimately manage their condition if it's a long-term condition, or prevent it from reoccurring if that's what you're hoping for.
Okay, thank you, Stephen. And this does link with a question that was a bit earlier in the chat, which is about, can somebody ask what an individual suffers from? Is there a generational link? Can it come from our family past history?
So that's a really, really good question. We know that's a really good question. There are certain conditions that have a strong family link. So, for example, heart disease, diabetes, stroke, lots of these other wider health issues we know have a link. We also know the link between diabetes, high blood pressure, high cholesterol, and let's say musculoskeletal pain, or knee arthritis, low back pain, neck pain. I would say it's probably more of an indirect link. So just because your father had osteoarthritis in his knee does not mean that you are going to get osteoarthritis in your knee. There are lots more other variables there that I would say are of greater magnitude or as a better predictor for that. So, for example, if your dad was 27 stone, smoked 30 cigarettes a day, drank 12 pints, had high cholesterol, high blood pressure, and had knee arthritis, and if you live that same lifestyle, chances are you're more likely to develop knee arthritis. Now, that's not familial. A lot of that is behavioural, and some of those genetics that you've inherited as well. So it's a bit speculative to say that all arthritis is inherited or musculoskeletal pains are inherited. But then also you've touched upon a really important thing, is that if both of your parents have had a history of low back pain, chronic back pain, and they're both, let's say, wheelchair bound because of that, and they have taught to you your entire life about low back pain, don't be in a wheelchair, that's going to affect your behaviours. That's going to affect your choices going forward in life. And it might be that sort of it's like a secondary effect to that you would then develop low back pain. It's not because you've inherited the same spine genes. It's more that you've inherited the same behavioural choices or the cultural beliefs or the same attitudes and behaviours, which are probably, as a predictor, more closely linked to arthritis.
Thank you, Stephen. That's really helpful. And Rachel's also responded to your comments about the physio and the charities and the money, and said it was really helpful what you've said would aid staff so much more. So thank you. So in the next myth that colleagues on the call would like busting is clicking joints are abnormal and must be arthritic.
My favourite myth, this one, Anne. My favourite myth. I think because we see so much of it, and it's a huge anxiety driver. Lots of people, I'm relatively well informed around this, so I can be a little bit blasé around it. But for those of people who aren't, it's an incredibly scary thing. You know, I've heard patients say my knee. If we talk about the knee, for example, a clicking knee, you know, the first thing that patients will come to me and say is my knee's wearing away. I've got bone-on-bone contact. I'm too young for this. I feel really old, I'm worried about this getting worse, I'm worried about my knee deteriorating, ultimately I'm perhaps worried about a knee replacement. And those are genuine anxieties and fully understandable as well. You know, Rice Krispie knees, like snap, crackle and pop. The caveat to this is that if the knee is clicking and it doesn't hurt, you don't have anything to worry about. If the knee is clicking and it's painful, you need to see a physiotherapist, or you need perhaps a little bit more further guidance and opinion. So this is just talking about a painless clicking of the knee. So the myth is that a clicking knee joint must be arthritis. As a result of people often having a clicking knee and the anxieties that it drives, it affects their behaviour. And understandably, they then go, like I mentioned earlier, I don't want to run on my knee because it clicks. I'm worried about wearing the bone out a lot quicker. So they avoid doing the activity, and inherently they get a little bit weaker. The knee clicks more, they get less active, it gets weaker, and then they may then start to enter a painful knee. The truth of the matter is that a clicking knee is perfectly normal if it's pain-free. Perfectly normal. 99% of individuals who have no knee pain have a clicking knee. And the cause behind that clicking is several different things. So remember, we're talking about a pain-free click. One of which is as a joint moves, there's a slight space within that joint. As the knee bends, fluid gets moved around that knee joint to lubricate it. And wherever fluid moves, you can get pockets of air that develop, so bubbles, effectively. And sometimes when you move in a certain way, you might just cause that bubble just to pop. So the best example of that is, ever children click their knuckles and do this? Now all they're doing is taking that joint through its full range of movement and dissipating gas within that joint space. If you have children and they're clicking their knuckles, I'm sorry, but it's not linked with arthritis. Clicking that knuckle will not result in that child having arthritis. So I think we've lost one there on them, but it's just a dissipation of gas. You can also get friction of certain structures like tendons that rub over the knee. So if this is a knee joint, it bends. So this here is your patellar tendon. And you've also got some tendons of all the muscles that attach and support the knee. If those muscles get slightly weaker, possibly because you've started noticing that your knee's clicking and you're worried, so you're not doing as much, those muscles get weaker, you get a little bit more friction, a little bit more laxity on those tendons, and that can rub over bone structures and cause clicking joints. A clicking knee joint is actually a sign of a very well lubricated knee joint. And in nature, interesting fact, antelopes use knee clicking as a sign of dominance. So the antelopes who've got the clickiest knees are the more dominant antelopes. It's actually seen as a biological advantage because they are showing that their joints are healthy. If the clicking, like I said, if the clicking becomes painful, you will need to see someone about that, because that could be lots of other things that I don't really want to talk about today, because the differential for that is quite large. But a painless clicking knee is no different to doing that. I'd also say your body makes noises. You know, when you're hungry, your stomach gargles. Does that necessarily mean that you've got a stomach problem? No. Now we all have gas and flatulence. You know, that shows that it's working fine. You know, things will click, things will clunk. If it's painless, it's nothing to worry about.
Brilliant, thanks, Stephen. And somebody's commented, we hear lots about looking after your back, but how do you look after your knees?
Really good question. Lots of different things can contribute to helping your knees get nice and strong. I think from my opinion, if you can get some regular physical activity, so some cardiovascular fitness, whether that be walking, swimming, Zumba, any Pilates, yoga, any form of physical activity to get your heart moving will help to look after your knees. If you can strengthen up your knees, which is really important to help keep your bones nice and strong, especially for females, if you can do some form of weightlifting, you don't have to squat 200 kilograms. You can just fill up a couple of bags full of sand or soil, or put a kid over your shoulder, do some squats. If you can do some weightlifting, some resistance training, as well as some cardiovascular fitness, that can be really, really good for your knees. A weight loss of 10% in an individual who's overweight, if they can lose 10% body weight, that improves the perceived symptoms of knee pain by 50%. So we know that there is a link between weight loss and knee pain, just simply because of the forces that go through that knee. And lots of other things can be really helpful for knee pain as well. Some really good supportive shoes. Don't overlook the importance of that. They're really important. There's a really big link with the Mediterranean diet and helping with knee joints. So lots of olive oil, lots of fish, lots of vegetables has been shown to have a really big impact on helping knees. Optimizing pain relief, if it is a really painful knee, optimizing those simple pain relief that if you're allowed to take, liaise with your doctor or your pharmacist and make sure that you're taking the right pain relief can be really important. And other things as well are using hot and cold modalities. So if in the winter, using a hot water bottle on your knee to help the blood flow to that knee can be really helpful. In the summer, using some peas in a frozen bag of peas in a wet towel can be really good for symptomatic relief. It won't do much more than that. It won't reduce swelling. It won't do anything magic. It might just help pain a little bit. But by and large, exercise, strengthening, eating the right things, using pain relief when you can, appropriate footwear, and the other lifestyle things such as, if you're smoking a lot, the cigarette smoke takes away the hemoglobin and the oxygen, because carbon dioxide binds to hemoglobin a lot better than oxygen does. So you're actually starving your joints of oxygen if you're smoking, which is why healing time is a lot longer for people who smoke, because they haven't got the blood flowing to those structures or tissues that are damaged to help them heal. So cut down on smoking if you can. You can utilize smoking cessation services through your GP. Alcohol can also contribute to that, more probably because it's associated with weight rather than the alcohol in itself being effective for knee joints. But overall, a package of care is what I would be looking at. There isn't a silver bullet. No, it's not buying a new pair of shoes will cure your knee pain. No, you have to do everything. It's hard work. But hopefully, if you find someone to help you along that journey, and be expected to do at least 3 months of these sorts of lifestyle changes, then you should hopefully start to get some improvements in your knee pain.
Brilliant, thank you, Stephen. And Tracy shared her experience of having having a bit of pain in the knees, seeing a physio, keeping going, started running, and feeling much better for it. Rachel has commented that she hears people cracking their knuckles and told, as you've said, it's letting air out, or that. But she says, I have a neck crack and sometimes I move a little different and my lower back or hip will crack. Please advise, most times my cracking can be painful. Yeah. She also says, thank you, so that makes me a less dominant antelope.
I'm sorry about that. But yes, if you've got pain, and it's a joint pain, a bony pain, or even if it's a muscle or a tendon or anything else, you're best seeking physiotherapy, in my honest opinion, because that's our remit. That's what we do. That's what we tend to see day in, day out. So if it's a painful click, go have an opinion on it, have an assessment, and be quite open and frank about what your concerns are. If you're scared, say you're scared. If you're worried about this becoming something that will get worse, say that's what you're worried about. And then it's hopefully something that once we assess you, if we can find a simple cause to it, of which I'll be honest, often there isn't. If we can find things that you could work on that could help it, then work closely with your physiotherapist and they'll help design a program which is tailored for you. So I would always encourage anyone, if they have a physiotherapy appointment, to leave nothing at the door. Even if that first appointment you do nothing but talk, outlay everything that is your worry and your concern and what you want out of your sessions. And that if you can have that open and honest relationship with your physiotherapist, your outcomes will be much, much better. And don't be afraid to change your physiotherapist if you don't get on with them. Your personality traits are different. So find someone who you get on with and you trust, and then that will help you with that clicking neck or that clicking hip, and it can be really, really helpful.
Brilliant, thank you, Stephen. And Rachel's commented that she's got a flatbed walking treadmill and is trying to reduce the weight and using Nivea and Albus oil together to rub on the area is concerned. And she's also commented, like you have, that decent shoes are, you have your feet carrying you around all your life, so yeah, that's really good. And then colleagues from NHFT have commented about self-referring to physio to seek support. It's really good. So I don't think I've missed any questions in the chat, but just being conscious of time. Is there anything you want to leave us with, Stephen, before I hand back to Robert?
Yeah, there is one thing actually. As part of sort of well-being, and I'm very conscious that I've sat here for an hour and not moved a great deal, so I'm a bit of a hypocrite, so my apologies. But we've launched through the Wellbeing Week, we've launched a stairs assessment, stairs challenge that individuals can do either on their own or as a team, where they're looking to see how many stairs that they can climb. Over the next sort of way, you can do it this week, they can do it over the course of a month or 3 months, just to see how they can boost their activity levels. So it's all on the wellbeing page. It's all gone through comms. But by the end of today, if people can climb 21 up the stairs, 21 flights of stairs, you'd have climbed the equivalent of the Millennium Dome. So that's something we all could try and do for today, is climb 21 flights of stairs. And then if you're feeling really ambitious with your friends or your team over the next couple of months, if you can climb 3,871 flights of stairs, then you've climbed the equivalent of Mount Everest. So good luck.
Brilliant. And we've put the link. The link is on the website to the Stair Climb Challenge, Stephen, but I have just put it in the chat for any colleagues that haven't seen it.
Okay.
Over to you, Robert.
Brilliant. Thank you so much. And thank you, Stephen, for a really insightful session as well. I mean, I was sitting on the edge of my chair doing those exercises as he was talking through them as well. And I know I did have a little chuckle to myself when you did talk about the knuckles. I often tell my children to stop doing that. But now I'll be able to correct them and say it's because they're just letting the air out.
Yeah. They're probably more dominant as well.
Yeah. Brilliant. Thank you so much. I'm just sharing my screen now. So want to go through some final slides with you all. So feedback is a gift. What we'd like you to do is, in the chat, we are going to post the link to a short survey, which we're asking everyone to complete to give us some feedback about the sessions. And that's really important because it helps us to shape future events around what you want and what you're looking for and how we can support you as well. So we are going to post the link into the chat box, or you can use the QR code that is on the screen at the moment. By entering your feedback, you do get entry into a prize draw to win one of the NHCP Festival Wellbeing bags, which have some goodies and such as books as well. But as it says on the screen, you need to be in it to win it. So please do take the time to give us some feedback around those. Just run through. Obviously, you've seen today lots of information around the Wellbeing Festival. We're coming to the end of day one, and it's been a fantastic day already. So please do make sure that you look out for the events across the rest of the week. Share with colleagues. Remember, they're going to be on demand as well. We need to create as much noise as we can in sharing information with our colleagues who haven't been able to join us today. It's such a fantastic opportunity. So please do make sure that you share with colleagues. So as Stephen was talking about the step challenge, we do have some other challenges as well across the week. So there is a photo challenge. Information can be found on the NHCP website. And we're also looking at creating a playlist, a Spotify playlist of everyone across the county's favourite songs, which gives them motivation, keeps them going. So please go onto the website, have a look how you submit that. And by the end of the week, we hope to have created a Spotify playlist that can be accessed for everyone. So also, we'd like to remind people to get social. So make that noise, make it across Twitter, through Instagram, Facebook. There's our handles are on there. We've also got hashtag Northants Wellbeing and hashtag VWBF 2021. Please do get that out there. We want to be trending across Twitter for Northants Wellbeing, raising the profile of what we're doing to support wellbeing of staff within health and social care. So do support us in this aim to drive that forward as well. And then finally, we just want to remind everyone that across the week, you may be hearing some stuff maybe that's going to be really emotive. That support is out there for you through the Stronger Together hub. We're looking at also the Changing Minds IAP service and the mental health number. So please do reach out if you need any additional support. Please just contact any of the numbers on the screen that are here for you. And a massive thank you for all joining us this afternoon for this session. We hope you've enjoyed it and look forward to seeing you on some of the other sessions across the rest of the week. So a massive thank you. Enjoy the rest of your day.